So if you're ready, I've started the timer and here is the question.
Okay.
Right. If you have read and understood, kindly begin your examination.
Yeah. So I wash my hands and
Yes?
I introduce myself. So I'm Dr. Sunday, one of the surgical doctor, and I'll be asked to carry out examination of your tummy. So
Yes?
this will include me taking a look at the tummy, feeling the tummy, then listening to the tummy. So is this all right? So I'll take permission. Then I will confirm the patient name, so and age. Then after that, then I will ask if the patient is in pain. So I can see the patient is in mild pain, and I will offer the patient pain medication if the pain is severe. Then I will then tell the patient about the exposure that I will need the patient to expose our tummy only down to the growing area, just while covering the private part. Then I will also tell the patient to lie down at first. Then, but I can decide to start on white standing just to be sure. Then the first thing is I will ask patient to cough. Then okay, before that, I will first observe the hand, check for any hand staining, any clothing, any changes in hand. Then I will check for pulse of hand. Then after that, I will move to the face. Then I will also check for any sign of perioral cyanosis. Then I'll check for paleness for the oral cavity and also there. Then after that, I will move to the abdomen. I will observe the abdomen, which I can see bulging while standing in the peri-umbilical region. Then I will ask the patient, so there's no doubt obvious deformity on a visual examination. Then I ask patient, I will also check the kind of respiration for the patient, whether it's abdominal or thorax or mix. Then I will ask patient to cough while standing. So I'm in coughing, maybe I can see the swelling increasing in size. Usually, then I'll move to palpation. Then for I'll first, as standing, I will ask patient to now cough while I palpate the swelling. So just to feel the swelling. Then the patient, I'll ask patient to cough. So I'll feel for cough impulse while standing. Then after that, I'll ask patient to lie down on on their back on the couch. So after lying down, with head slightly elevated about 30 degrees. So I'm relaxing the leg so that the abdominal muscle can relax. Then I will start general abdominal palpation officially, starting from and going anti-clockwise, starting from the left iliac fossa. So I will palpate all around. Then I will finish with periumbilical region. Then, which in this case I shouldn't see anything obvious during the palpation. Then after that I will do deep palpation. Then at the periumbilical region, then I will now palpate and I will for cough impulse again, or I can tell the patient to raise the head to tense the abdominal muscle to see if that will lead to increased bulging or not. Then after that, I will palpate the area. I will check for deep palpation of the area to check whether there is a pulsation in the swelling, whether if there is pulsation or not, the consistency, which will be dull inconsistency. Then I will check whether it's reducible or not. Then I will check for the size. Then I will check the entrance. Then I will also check if there's pulsation symptom pulsation sign is positive for the swelling. Then after checking that, then I will now ask the patient that I would like to auscultate uh, the swelling. So I will auscultate the swelling for any presence of growth or not. Then I also take time to auscultate for the renal artery that just lateral on the both side to the umbilicus. Then I also auscultate just above the swelling to check for any maybe abdominal aneurysm, aortic aneurysm. Then after that, after auscultation, then I will now try to do illumination test. So I would probably dim the light in the room, then make a paper, roll it to make a kind of a funnel. Then I would shine the light to the swelling. Then while checking from the other side with the paper to check for any transformation of the swelling or not. Then after that, then I will thank the patient. Then I will wash my hands. Then I would like to summarize my case. So before that, I would like to complete my examination by performing complete even rectal examination and the peritoneal examination, and also to complete maybe central cardiovascular examination also, and maybe chest examination if needed. So today I examined a 54-year-old female. So who complained the swelling of the umbilical region, and the swelling have been there for the last 6 years. So, however, the swelling is reducible, and right now it's becoming tender, and gradually turning to be non-reducible recently. So, and on physical examination, the patient was slightly in pain, which I offered pain medication, and the examination was normal. Then abdominal examination shows about 3 to 4 centimeter oval shape swelling just above the umbilicus. So, and this swelling is though in consistency, and there is no pulsation. It is currently not reducible, partially reducible right now, and slightly painful. And there's no other abdominal pathology or swelling, and there's no, yeah. So, and the swelling is also not transmitting, and there's no growth over the swelling. So, based on my findings,
So what are your
my
provisional
diagnosis
diagnosis?
will be umbilical hernia
Yes.
of the abdomen.
Okay.
So, and I would also like to
What are the
consider
other differential diagnosis that you will consider?
I would also consider the umbilical hernia, then diastasis of the rectus abdominal.
Yes.
Then I also consider maybe aneurysm of the abdominal aorta. Then I also consider, yeah. So those are my main differentials.
So what investigations would you do to confirm your diagnosis?
Okay, so first of all, I will take proper history of the patient. Then I will do basic blood analysis to check blood counts and the urinary electrolyte. Then also I would like to perform I would like to perform a abdominal CT scan, then ultrasound of abdomen. Excuse me. So abdominal CT scan and abdominal ultrasound can help me to delineate the cause of swelling and whether or not bowel is part of uh, is part of the hernia content. Then after that, I will discuss with the NDT and consultant, and we can plan the appropriate treatment, which in my opinion should be surgery to reduce the hernia. So,
What are
and
the
the surgery,
surgical options that you can offer this patient?
okay, so it's called a anoplasty or anorrhaphy. So whereby we have 3 main types. We have the inlay, sublay, and onlay. So, but with
Okay.
mesh.
Or intraperitoneal position with mesh.
Yeah, or call it IPOM.
Okay.
That's
What
laparoscopy
kind
IPOM.
of surgery would you offer, open or laparoscopic?
Okay, that will offer laparoscopy IPOM because the recovery period is shorter.
Okay.
So, and the outcome is also as good as the open.
Yes.
So, and of course, it's not use of mesh. So, and from static outcome is better.
Good. Thank you. Yes. Who would give feedback to Dr. Sunday? Dr. Abhishek or Dr. Saddam? Anyone? Dr. Roy? Anyone? It was good, Dr. Sunday. Just for because we have time. Yes, it was good. Did he miss anything? I guess no.
Yeah, I missed something.
Yes.
Yeah, I just
I'm
I
also
should have
having this feeling. Yes.
I
Would
think
you tell? Yes.
hernia, and so inguinal lymph node. I should have said I will also check for lymph node. Come
Examination,
again?
yeah. Yeah.
Yeah.
Yes, Dr. Abhishek.
No, ma'am, I was saying like I had a call actually. I just missed some portion, but
Okay,
Dr.
sorry.
Sandy, you did all the hernia examination like the cuff impulse and measured the size, transilluminated, and also listen to the hernia, right?
He did listen, but I
Yeah.
think maybe the cough impulse he forgot to ask.
So I did.
Like at the beginning of superficial palpation, we can
Palpation,
ask the
yeah.
patient to, yeah, ma'am.
I did cough impulse 3 times. First, while
Okay,
during looking at the patient, then while standing and while lying down. So I did it
okay.
3 times.
Okay,
All right,
no
thanks.
problem.
Yes,
Yes,
this
yes,
I
that's.
wasn't sure.
You measured the size with the tape, right?
He did mention when he was
Yeah. Okay.
explaining the
Then
case,
okay. Yes,
so
ma'am.
yes.
So
Then
And
okay,
he
fine.
even told the consistency, it was doughy. So with the hernia, he told everything. So that's good.
Yeah.
yeah.
Okay, ma'am. That's it.
So for the size, you can measure with tape or you can use your hand. We know that average hand is about 1.5 centimeters. So you can use if you have one finger or 2 fingers can enter the hernia orifice. 2 fingers like 3 centimeters. So maybe 2.5, that's about 4 or 5 centimeters. That's also a
Okay.
way of measuring, the
Yeah,
size.
good. And it was
Very
non,
good, ma'am. Yeah.
yeah, or reducible. Yes, good. Thank you. Started the timer, and here is your question. Right. If you have read and
Yes, ma'am.
understood, kindly begin your station. Tell me, considering it critical care station, how would you manage this patient?
Ma'am, I'm going to manage the patient according to ATLS protocol with
Yes.
ABCDE approach. I would like to attach the patient to a proper hemodynamic monitor and call for help, and I would seek an assistance help in that manner. If the patient is talking, I'll ask the patient with her name, with his name. If the patient can talk, I will secure that airway. After securing the airway, I will also restrict the movement of the cervical spine. After that, I'll check the patient's breathing status. By checking the patient's respiratory movement, use of accessory muscles of respiration, and also I'll check if there is any evidence of open chest injury. Sorry, ma'am, I'm having a call. Oh, no problem. Then I'll do after assessing is I'll check the breathing status, and after that I'll check the central tracheal position, and if there is any check the chest expansibility. And after doing assessing the breathing status of the patient, I'll quickly go for the circulatory status. As I'm suspecting the patient have something like crash syndrome, I would like to give the patient with adequate I will give the patient to IV cannula through to median cubital fill with both hand. With one IV cannula, I'd like to start vigorous fluid resuscitation to maintain urine output more than 300 ml per hour. And after that, I would like to maintain adequate diuresis by giving. Hello, ma'am.
Yes. Can you please tell me why the patient was noticed to be unconscious?
Ma'am, I am really sorry. Can you please pause for a second? I'm on
Yes,
duty and
yes,
having a
yes.
call from emergency, ma'am. I'm really sorry.
That's
Just a
okay.
second.
Okay. According to the injuries patient has attained, what grade of shock would you label the patient in?
So, okay. So the grade from a grade 3, stage 3 and above.
Okay. when there is loss, when there is crushed
I think
injury of
four.
the leg, how much blood
Yeah.
is lost?
Well, the blood on the percentage should be, I think, more than 40%,
Okay.
maybe.
Uh,
Yeah.
yes, patient was noticed to have high urea creatinine. Can you discuss why?
So the patient has high urea creatinine because of kidney involvement. So the patient is having crush leg, which means patient is having crush syndrome, that's leading to rhabdomyolysis, so which release intracellular component of the rhabdom skeletal muscle cells into the bloodstream, which is myoglobin and and other creatinine and urea, which now flows to the kidney and is now causing acute renal injury, which is why we have urea creatinine is high,
Okay.
and also potassium.
Yes. Can you name few other conditions in which patient also presents with acute kidney injury and high urea creatinine?
Okay, so first one we have compartment syndrome.
Okay.
Then we also have in severe burn, circumferential burn, deep burn,
Yes. Massive
then
burn. Yes.
and compartment syndrome. Yeah, that can be
This you have
secondary to.
mentioned. Yes.
Okay,
Anything else?
like,
Like acute ischemia in case of reperfusion injury,
yeah, yeah, acute ischemia and
and
also
in case of hyperthermia,
yes,
extreme heat and extreme cold conditions. Okay,
yeah.
can you tell me how a patient with rhabdomyolysis with acute kidney injury should be managed?
So first of all, we need to address the primary cause. For example, if you know that there is ongoing compartment syndrome, we need to decompress the compartment, which is very important. Then we need to manage hyperkalemia in this case. So, and what the primary management will be according to ABCD protocol, which has been done to stabilize the patient. Then also to give the patient directives. So then after that, yeah, directive is very, very important. Then monitor, then we have to, if depending on the eye level, eye calcium level, the level of potassium level in the blood, we need to first give calcium gluconate to protect the heart, to prevent cardiac complication. Then we need to give glucose plus insulin. So in order to reduce the potassium level in the blood, then we can also give
Can you tell me
salbutamol.
how forced diuresis is given to help patient in this condition?
So we give diuretics because most like for most diuretics that they will preserve sodium and water, whereby
Yes.
increasing elimination of the potassium from the body,
So what would you
and that will
use? Yes.
so we can give normal diuretics that work in the collecting duct. For example, we can stimulate aldosterone, which then, but the most common one will be thiazide. Look to reti, sorry, furosemide.
Mannitol, it says. Okay. How would you alkalinize the urine? What measures would you use?
To do what?
Alkalinization of the urine?
Okay, I'll give a sodium carbonate.
Yes. Okay. Can you tell me what are the signs of compartment syndrome or the clinical features that you'll observe?
Okay, so the clinical syndrome will be pain. So this pain that is so severe in intensity, and the pain that is not being cured by normal analgesic, and also the patient might be having in the late stage, the patient can be having reduction in the sensation of the limb or the affected side, then muscular paralysis of the affected side also. But the most important one is pain that is so persistent that even after giving morphine, it reduces to go, and the pain on passive, extension of the affected compartment.
Okay. Anything else? There are 5 P's. You have to tell me all 5 P's. Okay,
Okay,
later. Can you tell me how would you do fasciotomy? Is there a special way
so
of?
yeah, so fasciotomy depending on the affected limb. So like in this patient now, so we have a right leg. So for the right leg, so we have to do lateral fasciotomy and the medial. So for the medial one anterolateral one we assess both the anterior compartment and the lateral compartment. But the medial one we assess both the superficial and the deep posterior compartment.
Can you tell me why the patient has raised potassium levels and how would you manage that?
Okay, okay, so there's raised potassium level because of the intracellular release of the potassium. So the muscle cells have higher potassium level in the sarcoplasmic reticulum. So destruction of the muscle cell, which is during the abdominolysis, will release the potassium into the bloodstream, which will cause raised potassium level. And management, according to ABCD protocol, then give a fluid and thiazide. So sorry, diuretics. Also give the calcium gluconase to stabilize the heart, then give insulin and glucose to promote the calcium inflow into the cell. Then also we can now give salbutamol also to help to reduce potassium level in the blood. And
Can you
calcium gluconase.
define the term myoglobin? What
So
is myoglobin? Yes.
myoglobin is a specialized protein that is found in the skeletal muscle cells, so which helps in contraction. So no, sorry, not contraction, which helps in the transporting the of the oxygen.
It's How many globin chain does it contain? Single globin chain.
Yeah.
Okay.
Yeah.
And it's a source of oxygen for muscles during increased activity. Can you explain, one last question, what is the mechanism behind causing acute renal failure in the patient with compartment syndrome?
So the mechanism is it follows the after abdominolysis. So that's release of the intracellular content into the blood. So this content includes high potassium, myoglobin, even purine derivative. So and everything goes to the kidney. So in the kidney, so the myoglobin and high potassium, especially myoglobin, will accumulate at the podocyte. So which will cause destruction and injury to the podocyte, causing acute renal failure.
Can you please tell me what are the labs which are important for the diagnosis in this patient?
Important lab. Okay, so first potassium level, then urea level, creatinine level that will show whether there's presence of or absence of a acute kidney injury. Potassium level that will show hyperkalemia, which is very important. Then ABG that will show whether it's acidosis or not. Then we have intracellular components like creatinine kinase, CK. Then
Yes.
then
What
level
is the
of
role of
purine.
CK in case of this patient? Elevated CK.
Yeah, so CK creatinine kinase. So these are special protein. So and they are found in muscle cells, for example, cardiac muscle cells, skeletal muscle cells, depending on their type. So and in case of rhabdomyolysis, which is the breakdown of the muscle cells during necrosis, they'll be released into the blood, causing the elevation of their level in the blood.
Good, thank you. Yes, needs little brushing up, otherwise it was good.
Yeah.
Thanks.
Oh, I miss ECG monitoring. Thank you,
Yes.
Dr. Laila. ECG.